Good morning. Today we have a very important webinar on endometriosis. This webinar has been organized by the European Society of Gynecology in collaboration with an important European society, the European Endometriosis League. I am Professor Stefano Angioni, the head of the Obstetrics and Gynecology Department of the University of Cagliari. The title of our webinar is Endometriosis, New Insights and Controversies. We have many important speakers, and I introduce the first one is Professor Angelos Daniilidis, that is a full professor in obstetrics and gynecology at Aristotle University of Thessaloniki, Greece. His clinical and academic interest is focused on endoscopic surgery, reproductive medicine, quality improvement in clinical and educational practice, is specialized in gynecological endoscopy and reproductive medicine. He has many official tasks in many important societies, the European Society of Gynecological Endoscopy, the European Society di ESG, of human reproduction. Is the director of the Master of Science in Surgical Application of Endoscopic Surgery in Gynecology. Professor Daniilidis will present surgical treatment of endometriomas. Please, Angelos, your turn.
Thank you very much, Professor Angioni, for this introduction. And I would like to say that it's a great honor and pleasure for me to participate in this webinar organized by the European Society of Gynecology in collaboration with the European Endometriosis League. And I'm really happy to be here, and I would like to congratulate them for the great job they are doing in order to help young colleagues all over Europe to listen new things. This is my declaration of interest. I have nothing to declare apart from the fact that I have been invited by friends. So my presentation is regarding the surgical treatment of endometriomas. And the key points actually of this presentation will be three. What will be the available surgical treatments for endometrioma? What is the safety of surgery, and what about ovarian reserve? And lastly, what is the impact of endometrioma on the IVF ICSI outcomes? And what about laparoscopy prior to ART? Starting from the beginning, when we discuss about surgery for endometriomas, we need to consider several aspects and things. That it is a surgeon-dependent operation. There might be a delay in commencing ART. There is the cost of surgery, the risk of surgical complications, and of course the potential adverse effect on ovarian reserve. Surgery is not always straightforward, especially when we're talking about endometriosis and endometrioma. We operate young women, and it's important even the first operation to be performed by the most experts. And our objectives are to reduce the pain and to improve fertility of these women without causing any damage. And according to the ESG guidelines, we may consider operative laparoscopy for the treatment of endometrioma-associated infertility, as it might increase the chance for natural pregnancy. And when we perform this operation for ovarian endometrioma, we may consider either cystectomy or a CO2 laser vaporization, as both techniques appear to have similar results. And indeed, it's been shown by various studies like this one that surgical treatment of endometrioma will improve the chances for these women to achieve spontaneous pregnancy in percentages which are similar with 2 to 3 IVF cycles post-operatively. There are several surgical options as they have been revised and they have been recommended by ESG and ESG. Cystectomy is one technique, the stripping technique. Ablative methods, the use of laser, bipolar coagulation, plasma energy, and sclerotherapy. And the combined technique, which is actually combining the first two techniques in another way. Cystectomy has been considered everywhere the gold standard technique for treating endometrioma. It has been used for a lot of decades now. It has been shown that it is better than ablation regarding the risk of recurrence of endometrioma or the risk of recurrence of pain, and it seems that it has better results in comparison to ablative techniques as for the spontaneous conception of these women. Of course, it is an operation that requires surgical skills. The dissection and detachment of the capsule of the endometrioma is not always straightforward and easy, and the surgeon needs to have the ability and the endoscopic skills to do so without damaging the tissue. This is why some authors proposed combined techniques, especially when we're talking about large endometriomas, when there is the risk to cause damage by removing the capsule of the endometrioma. That means to combine cystectomy with the use of CO2 laser or drainage and GnRH ablation as a less aggressive approach for large endometriomas. It's been shown that both cystectomy and laser vaporization have similar results. This is a randomized trial a few years ago, which has shown that as for the recurrence rates and the pregnancy rates post-op, within 6 months after the operation, we have similar results with both techniques. And this is a more recent meta-analysis for the same subject, comparing laser, cystectomy, and ablation with diathermy. Cystectomy seems to be better than other techniques regarding the recurrence and of endometrioma or the symptoms. But as for the pregnancy rates, it seems that both cystectomy and the laser ablation have similar results, and they are superior than performing a fenestration and using just the bipolar coagulation. Of course, we need to be careful. There is the safety issue, and when we're talking about safety on endometriomas and ovaries, we mean the ovarian reserve. When we perform surgery for ovarian endometrioma, we should be very, very careful, and specific caution should be used to minimize the ovarian damage. Both ESTRA and the NICE guidelines have a similar approach to that. It's been shown that there is a negative impact to the ovarian reserve when we operate endometriomas. There will be a reduction to both AMH and other follicles of these women post-operatively. And actually, this negative impact to the ovarian reserve due to the operation we perform will be more pronounced, more severe when we have to operate bilateral disease. The size of the cyst plays a role. The bigger the endometrioma, the higher the risk is to cause more damage to this ovary. And of course, when we have to reoperate, then things might become very harmful for the ovarian reserve and the volume of the ovaries after the second operation. It seems that for both cystectomy and ablative techniques, a size between 4 to 5 centimeters is crucial, and beyond this size, the risk of reduction of AMH is more significant. Cystectomy is the gold standard technique and has been the gold standard technique, but it seems that it causing sometimes damage to the ovarian reserve. And why is that? It's not only the technique, but it is actually the methods we're using for hemostasis. It seems that if we use bipolar diathermy, this damage is more pronounced. But if we use other methods like this RCT says, non-thermal hemostasis, then the results of AMH post-operatively will be better. And another RCT for the same subject, here the authors are comparing cystectomy and then for hemostasis bipolar energy versus suturing, and it seems that it's better to place a stitch on the ovary than using the bipolar, as the AMH decline is less. And also another randomized trial, again with unilateral endometriomas and AMH levels. Here the comparison is between coagulation and hemostatic agent, and the results of course are in favor of the hemostatic agent and not the coagulation technique after the cystectomy with bipolar energy. And a recent meta-analysis which is describing very well all these outcomes and placing the point that we should be very, very careful with the use of bipolar energy after performing a cystectomy, and perhaps we should try to use either a stitch or a hemostatic agent when we have a lot of bleeding instead of using bipolar energy, because this is not going to reduce so much the AMH of these women post-operatively. Of course, we have data and new literature regarding the pathophysiology, and we do know that when we talk about endometrioma, it is actually the superficial layer of the glands which is causing the problem. Perhaps we should focus to treat only this and not to remove the whole capsule, which has a depth of 1 or 2 millimeters and even more. So the novel approach, the novel techniques like the laser ablation, the new type of laser or the plasma energy, they're actually destroying the tissue in depth of about 1 millimeter. There's no thermal spread around to the healthy tissue, and this might respect more the healthy ovarian tissue and the ovarian reserve post-operatively of these women. And there is data about these techniques, which are technically even more easy than a cystectomy. This is a multicenter RCT. Here, authors actually randomized the sizes of the ovaries of the same patient. We are talking about bilateral disease. One endometrioma of the same patient has been treated with a cystectomy, and the other one with a combined CO2 laser technique. And it seems that the ovarian volume was reduced only for the ovaries of the same patients who have been treated with a cystectomy. And this is another randomized trial again, comparing cystectomy versus laser for endometriomas of more than 3 centimeters. And a follow-up for a few years. And we have had lower antral follicles and lower AMH for the cases with cystectomy. And this is a large cohort for the safety of the use of endometrioma, a 30 minutes follow-up for more than 100 patients treated with CO2 laser, comparing with cystectomy, and we have similar results regarding the risk of recurrence. That means that the laser is also as safe as cystectomy. And of course, there are also other approaches like sclerotherapy, which has been used by several centers, either by laparoscopic approach, as we see from the group of Roman, or via transvaginal ultrasound, aspiration, and then puncture aspiration of the cyst, and then flushing with alcohol solution. And there is data about this technique post-operatively of chances of achieving pregnancy spontaneously after the treatment with a percentage of more than 40%. And there is also a recent systematic review of all the data for both laparoscopic and via ultrasound approach for sclerotherapy, and we have similar results of spontaneous pregnancy rates between 40 and 50% post-operatively. So it seems that also sclerotherapy is another approach. And as for safety, there is this meta-analysis in 2023 comparing cystectomy versus sclerotherapy. Recurrence, there's no difference between the two techniques, and also for the clinical pregnancy rates. Actually, again, between the two techniques, we have no significant difference. It seems that when we operate, we improve the fertility of our patients, but we need to be prudent, because there might be a negative impact to the ovarian reserve of our patients, especially if we are performing a cystectomy or if we are using laser. And this systematic review and meta-analysis in fertility sterility demonstrates this fact, that both techniques will have a negative effect. Perhaps in cases with cystectomy, it might be more profound. What about IVF and surgery for endometriomas? Does the removal of endometrioma before IVF improve the success rates of our technique? Actually, surgery for endometrioma prior to IRT can be considered in order to improve the symptoms of pain or accessibility of follicles. There's no other indication. Actually, an operation before an IVF for endometrioma is not going to improve at all the outcome of IVF. This is what Esther says, and there is data about that, like this large meta-analysis by Hampton and colleagues with 33 studies, with a lot of patients, comparing initially cases with endometrioma and no endometrioma, and they didn't find any difference to the IVF outcome regarding live birth rate and clinical birth rates. And the subgroup analysis of the same data, cases with treated endometrioma and cases with intact endometrioma. Again, we see that the IVF outcome is not different regarding the live birth rates, the clinical birth rates, and the number of oocytes retrieved with the IVF. And the more recent meta-analysis for all the fertility outcomes and the data during the ERT and the presence or not of endometrioma. We use according to the authors, if we compare with a group with no endometrioma, the same total amount of gonadotrophes for stimulation, the same duration of stimulation, perhaps lower number of oocytes for the cases with endometrioma, but we have in the end the same number of embryos, the same number of high quality embryos, the same number of implantation rate, clinical pregnancy rate, and live birth rates, irrespective if we have endometrioma or no, when we perform IVF. And we have some concerning data from this recently published meta-analysis. Here, authors claim that because of surgery, sometimes we have a higher cancellation rate with IVF, and perhaps in some cases, the live birth rate per cycle is significantly reduced for cases who have been treated surgically before IVF or ICSI. It seems that, and of course, we all know that decision-making endometriosis is not straightforward, and we have to consider a lot of things: the type of the disease, if we have a deep endometriosis, endometriosis, endometriomas, complications of surgery, risk of malignancy, but also risk for complications, the presence or no of symptoms, fertility factors of the couple, previous surgery, duration of fertility, desire for pregnancy, of course, and of course, if the patient wants to go for natural conception, then surgery is the only solution for these cases. This is an overview of all available treatments for endometriomas and the outcome of our surgery for pregnancy, for recurrence rates, for the effect to AMH. And if we see first for pregnancy rates, we have similar results for almost all the techniques which have been proposed, apart from electrosurgery, bipolar energy. That means that we have worse results when we use that. As for recurrence rates, again, we have similar results for all techniques, but we have worse results for electrosurgery. So that means that this technique of aspiration and then cauterization with bipolar energy should be abandoned. And then we have the effect of EMH. It seems that laser, plasma, and sclerotherapy might be better for preserving the EMH. For electrosurgery, again, the data are devastating, but for cystectomy, we have a question mark because most of the studies are older before knowing the possible negative effect of bipolar energy for hemostasis. And it seems that if we improve our technique and we use less of bipolar energy for hemostasis after cystectomy, we will have similar results for the effect of on AMH post-operatively. It is very important to be very, very careful when we have to reoperate endometrioma, and it's fundamental to know if there is a desire of pregnancy or no. If there's no desire of pregnancy, we could, if we have a recurrence, try first of all the medical treatment. And if the medical treatment is not successful after 3 months or more, then either to change the treatment or to decide to go for an operation, depending on the severity of the symptoms. But if there is a desire of pregnancy, then we have to know and ask if this desire is immediate or it is for a future. If it's for the future, then we should advise a patient for preservation follicles to stimulate and preserve follicles. If the need is immediate, then we go for a fertility workup and we advise for ART technology. And of course, before performing an operation, we could be able to predict whether there will be a poor post-operative outcome for the ovarian reserve. First of all, depending on the indications that we are going to operate or not. There are cases who are more favorable to be operated and cases that we need to be very, very careful. And of course, when we have bilateral disease, then the outcome will be worse. When we have to reoperate, recurrence, of course, the risk is higher. When we treat large endometriomas, more than 5 centimeters, then there is a higher risk for damage of the ovarian tissue. The higher the stage for deep endometriosis, for example, the outcome will be worse. And of course, preoperatively, when we already have very, very low AMH levels, then that means that postoperatively these levels are not going to improve, but they're going to be worse. When should we operate endometrioma? There's not a lot of data about that, but there is this nice prospective RCT. And according to the authors, perhaps the most favorable window to operate a case of endometrioma is the late luteal phase because of the edema in the ovary. The borders between the capsule and the healthy tissue is more loose and it is easier to detach. And they found out that for these women who have been treated by operation in this phase of the menstrual cycle, the results for the AMH decline were better than the rest of the patients. And some authors actually advise pretreatment, medical pretreatment. This RCT actually has demonstrated that pretreatment 2 to 3 months with a progesterone pill might have a more favorable outcome for the AMH after a cystectomy. Of course, there are a lot of things to know and literature is ongoing, but as a conclusion, we could say that the reduction of the ovarian reserve after surgery for endometrioma is actually inevitable, regardless the technique we are using. But this decline of the ovarian reserve is multifactorial, and it depends on our surgical skills, it depends on the size of the endometrioma, and on the history of the patient. Surgical treatment priority in order to improve only fertility cannot be recommended in general, but only in specific indications when we have pain or when we are not able to retrieve the follicles. Novel technologies like the new dead laser and sclerotherapy might be more promising for the AMH preservation. And let's not forget that now we can counsel our patients, and if we see high risk, then we could advise for egg freezing before performing an operation. I would like to thank you all for attending to this webinar and to congratulate again the European Society of Gynecology and the European Endometriosis League for taking this opportunity and offering to all colleagues in Europe this nice webinar. Thank you very much.
Thank you, Angelos, for your brilliant and comprehensive presentation. Now I have the pleasure to introduce the next speaker. Next speaker is Professor Mohamed Mabrouk. Mohamed Mabrouk is a very well-known expert in endometriosis. Actually, he's consultant gynecologist and minimal access reproductive surgeon in the UK, consultant on gynecologist and endometriosis surgeon at the University College of London Hospital. He is in particular president of the European Endometriosis League. I welcome him that has even many academic important positions. He's honorary professor of gynecology at the University College of London, adjunct professor of gynecology at the University of Southern Denmark, professor of gene at Alexandria University, Egypt. So, Mohamed, please give your presentation on endometriosis surgery, the conservative radicality, please.
Okay, so thank you very much for the kind invitation for this fantastic webinar, and thanks to friends like Angelos and Stefano for the arranging this fantastic opportunity for the European Society and for the EEL. Together, we have one aim, which is improving care to our patients with endometriosis. So today I've been asked to speak about endometriosis surgery, and thank you, Stefano, for the lovely presentation and introduction. I really don't deserve all this, so thank you very much. So endometriosis surgery, and instead of speaking about techniques, I thought about speaking about concepts. So we will speak today about management of deep endometriosis, and I would like to remind you that deep endometriosis is when there is endometriosis that's underneath the peritoneum that affects pelvic or extrapelvic structures. So you can see here that endometriosis can be in the ovary, can be in the peritoneum, and can be beneath the peritoneum, which is the deep endometriosis. Unfortunately, the more we go, the more we become involved in teaching and training for endometriosis, we still see colleagues who believe that endometriosis is just the chocolate cyst of the ovary, and or these little lesions here on the peritoneum, but actually this is just the tip of the iceberg. And data shows that ovarian endometriosis, isolated ovarian endometriosis, is only representing 14% of the cases, which means that 86% of the cases can have deep endometriosis. Deep endometriosis is a challenging disease, yes, and there are some challenges related to the disease management in general. Basically, the precise diagnosis, the decision-making, and some technical challenges related to the disease itself. So the precise diagnosis, unfortunately, is you read the literature, you find people saying that the ultrasound is the most accurate way, others who declare the MRI as the only way, and some schools that say, well, diagnostic laparoscopy is the best. Many ignore clinical diagnosis and clinical examination and listening to the patients and symptom analysis and examining the patients. And my opinion is it depends where you work, because if you work in a facility where ultrasound is advanced, then ultrasound is the best for you. And if MRI is the best and they're very skilled and trained to diagnose endometriosis, then I agree, it is the best. Diagnostic laparoscopy should not be used to diagnose endometriosis, and I hope no one among the audience still utilizing diagnostic laparoscopy as a diagnostic tool for endometriosis. And in principle, eyes do not see what mind does not know. And this is what the NICE guidelines in 2024, November, published some months ago, November 2024, focused on these concepts that eyes do not see what mind does not know. So if you do an ultrasound scan and it is negative, don't exclude endometriosis. My opinion is if you are an endometriosis, whatever, doctor, specialist, surgeon, fertility, you need to learn at least the basic skills for diagnosing ultrasound, for diagnosing endometriosis by ultrasound. Endometriosis can significantly impact the quality of life of the patient, and infertility is also a significant problem rather than pain. And we have to consider referring patients to fertility specialists if we need that, and if the patient needs to be seen by a fertility team. Decision-making in endometriosis is not an easy task, especially for deep endometriosis. And this is why pre-operative decision-making and intraoperative decision-making should be as precise as possible. You will hear this word many times. Endometriosis is an oncomimetic disease. Oncomimetic means it looks like oncology. It seems to be oncology. It looks in so many ways in the biological behavior, invasiveness, etc., like tumors. But if you look to this algorithm for endometrial cancer, for example, it's very clear. Stage 1, grade 1, this is the treatment. Stage 2, grade 3, this is the treatment. This is not, also because this is related to patient survival. In endometriosis, it's not the same. You can find the same lesion, same patient, different phases of her reproductive life. And this, with every patient, every phase, the decision is totally different. Technical challenges, yes. Technical challenges is a big topic here, because in oncology, for example, you remove. Here you have to be conservatively radical, which means that you have to remember that you're still operating a young lady in her reproductive age. You need to remove as much as possible from the disease and to be as conservative as possible on the patient's functions, on the patient's ovaries, reproductive functions, but also nerve functions and organ functions. And this is why I thought of sharing some important concepts with you. We need to do for every patient one successful surgery, to be as complete as possible in the disease and as conservative as possible on the organs and nerves. We need to integrate between endometriosis and fertility teams. It's a multidisciplinary surgery where it's not a one-man show. If you are a pelvic surgeon and you have the facility to run the surgery alone, that's okay. But it's much better to be done in a multidisciplinary team where you have the urologist, the colorectal surgeon, and other healthcare professionals that at the end aim at providing 360 degrees care to the patients. Our role in this context is to give options and information to the patient and help the patient to make an informed decision. Again, every patient chooses for herself what's good for her in this phase of her life. We are not treating lesions. We are treating patients. And we are not technicians. We are clinicians. We are not just doing a technique and removing a lesion. This has to be tailored to the patient's objectives in this phase of her life. So we have also to counsel our patients about the risks and the benefits very thoroughly, because dysfunctions in a patient who is 25 years old, having to self-catheterize herself for the rest of her life is a significant serious complication. Maybe she would not accept this. And the change, we have to counsel our patients that decision can be changed during surgery. And again, there is no one size fits all. Long list of perioperative complications can happen, but also dysfunctional complications. And this is why we come again to the question, how radical should we be radical? If you look to this paper by Negrar team, 2009, you can see that yes, comparing shaved disc and segment resection of the bowel, the less the better. And this is where, when we started the surgery for deep endometriosis some years ago, this was the usual specimen that people used to remove. Why? Because they thought that this can help the patient to prevent recurrence. We conducted this study in 2012 on human reproduction, where we found no significant difference between excising what you have seen and excising the lesion with 1 centimeter above and 1 centimeter below in terms of recurrence, pain recurrence, anatomical recurrence, or patient satisfaction, or patient's quality of life. And this is why I'll show you some examples for surgery. For example, this is a bladder endometriosis, where, as you can see, we start our surgery with a cystoscopy to see where the endometriosis lesions are. As you can see here, they are close to the trigon of the bladder. Our surgery doesn't aim at removing a big part of the bladder. We aim at removing the lesion, some safety margin around the lesion, and to reconstruct the bladder, conserving its functionality. And other examples are, for example, here, when we operate on the contrary, on deep endometriosis of the posterior compartment, we need to remember the nerves. And as you can see here, this is a real slide from a histology slide. And as you can see, this is endometriosis like a dinosaur. And what's being eaten here is the nerve. And this tells you the relationship between endometriosis and nerves. Endometriosis is a neurotrophic disease, and there is a lot of neuroangiogenesis. And this disease goes to attack the nerves. And this is why, as we start always in our surgery, we start far away from the lesion, this posterior compartment disease, where we try to find the right plane of cleavage, conserve the ureteric vascularization, open high at the level of the sacral promontory, and finding the autonomic nerves. As you can see here, we find the pelvic splanchnic nerves, hypogastric nerves, inferior hypogastric plexus, and then we lateralize these important structures. And once these are secured, we move to do the surgical excision of endometriosis, of the bowel, of whatever, of the posterior compartment. We have done several studies to compare this in cadavers and also in live patients. And we published this about a cartography of the autonomic nerves. And it's easy, it's not difficult, but you just have to keep it in mind that you need to identify the autonomic nerves before starting your surgery to avoid autonomic dysfunctions after the surgery. And again, in bowel endometriosis, for example, we always start, or try at least to start our surgery with a conservative approach. We aim at conserving, we aim at shaving, and if not possible, we do disc resection, and if not possible, we do segment resection. And again, the concept is the economic radicality, or the less, the better. But not only, the most important thing is that we keep in mind that we will do excision, total excision of the endometriosis, and we'll do one successful surgery. Here, as you can see, we identify the nerves first, and once identified, we identify the ureter and the pelvic side wall, and then we centralize the disease, we detach it from the bowel, and then, yes, we do free the bowel and do the segment resection of the bowel. Different examples to approaching the disease here. As you can see, the bowel is wrapped around the ovary, and here, this is where we try to defreeze this frozen pelvis, and then we remove the endometriosis, do the hysterectomy in a safe way. And again, here with endometriosis, every little helps. So for example, in this patient, we tried to use ICG inside the ureters. This helps us to see in overlay mode the ureters during surgery. We don't put stents inside the ureter, but we inject ICG inside the ureters. And at the end, after the segment bowel resection, as you can see here, we do an angiography to see how the vascularization around the joint is. And this helps us significantly to identify if the vascularization is good of the ureter, of the bowel, especially after the joint, and to avoid any ischemic complications after the surgeries, etc., etc. It helps. Every little helps. So last but not least, where to manage deep endometriosis, and it's not new. It is since 2006, and then in Europe that there has been the call for having, and then in 2013, for having endometriosis, especially deep endometriosis, managed in endometriosis networks or centers of expertise. We recently had conducted a Delphi study that is now in press on the Lancet about the criteria for accreditation of endometriosis centers, and this was a Delphi consensus study that we performed through the EEL with 25 endometriosis experts around the world, and this the results will be published very soon. So, concluding, multidisciplinary surgery for deep endometriosis should be done in endometriosis specialized centers where the patient is at the center. It's a patient-centered care. It's a patient-oriented, problem-oriented, not lesion-oriented. A lot of healthcare professionals around the patient trying to offer 360-degree care, from the endometriosis specialist to the colorectal surgeon, urologist, urogynecologist, psychologist, pain therapist, a lot of healthcare professionals. And this is actually at the end the aim. And by this, I would like to conclude by inviting you all, Italians and non, to be with us in Bologna in April 23rd to the 25th in our 8th European Endometriosis Congress. We have very interesting workshops, hands-on training, and also world-renowned experts, and we are all waiting for you there. Thanks again for the opportunity, and I wish you a fantastic rest of the webinar. Thank you.
Thank you, Mohamed, for your brilliant presentation. Your philosophy is absolutely correct. When we have to manage endometriosis, we have to feel this approach, that it is very important. Now I give the words to the last speaker, and the last speaker is Dr. Alin Constantin. Alin is the head of the Endometriosis Center at Saarland University Medical Center in Germany. He serves as Vice President of the European Endometriosis League and is a co-founding member of the Endoscan Africa and the Pan-African Society of Endometriosis. He is specialized in the ultrasound diagnosis and minimally invasive surgical management of endometriosis and adenomyosis. He will present, in fact, ultrasonography for the diagnosis of endometriosis as a first-line approach. Please, Alin, welcome.
Thank you, Stefano, for the kind words. And thank you, ESG, Both Mohamed and myself are very happy to join this webinar with so many attendees. So it's my pleasure to talk about ultrasonography for the diagnosis of endometriosis as the first-line approach. So far, we had very interesting presentations, very complex and challenging topics on how to treat endometriomas, on how to treat deep endometriosis, but we've skipped an important step, and that is the diagnosis of endometriosis. So I'll try to convince you why ultrasound is really the first line approach to diagnose endometriosis with its advantages and, let's say, limitations. I don't have any conflict of interest regarding this presentation. So the first thing I'd like to mention is that we're having two main issues when we talk about the treatment and the diagnosis of endometriosis. One is that we still have a very long delay of diagnosis from the beginning of the symptoms up to the diagnosis, 6 to 10 years, which is unacceptable. And then the other issue is the repetitive, unnecessary surgeries that these endometriosis patients are having. And in this very nice paper from Horace Roman and Benjamin Merlot from IFEM Endo from Bordeaux, they've shown that a patient has a risk of 28% to require a repeated surgical procedure 10 years after the complete excision of endometriosis. And please keep in mind, this is a study which was conducted in IFEM Endo, which is a top endometriosis center. So we can only imagine how is the reality outside endometriosis center specialized, so high specialized for endometriosis. So which are the challenges to diagnose endometriosis? Well, we basically have 4 pillars for the diagnosis. And as Mohamed was mentioning earlier, it's not just about the imaging. It's also very important to listen to the patient, ask questions, and conduct history taking, examine these patients. Again, a crucial step for the diagnosis of endometriosis, and we'll see right away why. Then the imaging, should that be ultrasound and or MRI, and last but not least, the laparoscopy, which, as we know, since the last ESG guidelines, is no longer the diagnosis gold standard to diagnose endometriosis, and is recommended only in patients with negative imaging and or unsuccessful or inappropriate treatment. I think it's important to add here negative imaging, as long as this has been conducted by an adequate trained sonographer or radiologist. So first things first, patient history. We have to talk to our patients, ask them questions, and understand everything about previous surgeries, previous pregnancies, infertility, child wish, any past treatments for endometriosis, medical treatment. Then we have to go and ask for the specific and for the typical symptoms, the 4Ds, dysmenorrhea, dyspareunia, dyschezia, dysuria. What can help us a lot and also save time and help us with the follow-up are the questionnaires, which can save us a lot of time. And we can see after 3 weeks, 6 weeks, 6 months, 3 months, 6 months after the surgery or after medical treatment, how has the condition of our patients improved. Then physical examination, extremely important. We should use a separate specula because it's easier to visualize the posterior vaginal fornix. By manual examination, when it's needed, not only a vaginal palpation, but also rectovaginal palpation when we're suspecting rectovaginal disease. And we should also look for abdominal scars. So as you can see here, it's important to use the specula and visualize the posterior vaginal fornix, because such lesions are very often just the tip of the iceberg. So posterior vaginal fornix infiltrated can be a sign that this lesion goes deeper and can infiltrate deeper structures such as the rectovaginal septum or the anterior rectal wall. Also, looking for the scars is very important, not to miss, for example, umbilical endometriosis or C-section scar endometriosis, but usually these patients are complaining and they tell us about the typical cyclical symptoms localized at the level of the scars. So why is imaging important? Because we don't want that such surprises or such surgeries are going to be a surprise. such a frozen pelvis where we don't know exactly if the bowel over here is attached to the uterosacral ligament with or without an infiltration of the rectal wall. So this is basically the challenge when we deal with deep endometriosis. We're basically flying over a frozen ocean, seeing just the tip of the iceberg without knowing what lies below the sea level. So that's why ultrasound can help us to uncover this iceberg of ignorance. Now, should it be ultrasound or MRI? I think it depends a lot on where you are seeing your patient. Depends a lot if you have an expert radiologist, if you can do advanced ultrasound yourself, or if you have a sonographer that is reliable. Doesn't really matter. It's important to get a good diagnosis performed by a specialist in ultrasound or MRI. Now, talking about ultrasound, these are the 4 most important papers. We have the IDEA consensus paper. All of these are free access, so you can find them on the White Journal website. So we have the IDEA consensus from 2016. Then we have the addendum, which came in December 2023 to cover also the lateral compartment, the parametrium. And then we have the revised MUSA criteria from 2021. And last year, the Inter-Society consensus on non-invasive imaging techniques. And I think these 2 things here are the most important lines from this paper. And I'll read them to you. And I think this is a message we have to share further. That patients with a plan for surgical intervention for endometriosis should undergo pre-op imaging for the detection of deep endometriosis performed by adequately trained operators. So the people performing the ultrasound or the MRI should be adequately trained. What does it mean? I think this is still an open discussion, and I think societies specialized in endometriosis have to define this criteria as well. And the second idea, and also very important, is that TVS performed by adequately trained operators is recommended as first-line imaging. Why? Because this is a tool that is available. It has a good test performance. It has a good cost efficacy, and it's also low. It has a low environmental impact when compared to other imaging tools such as the MRI. But it's also important that we all speak the same language, and the hashtag ENSIAN classification helps us. The P from Mexico coming over to Greece, to you, Angelos, you can read the hashtag ENSIAN code and you know exactly where the disease was localized. And the hashtag ENSIAN has also good accuracy when it comes to the ultrasound diagnosis. And for that, we have a good retrospective study from the group of Di Giovanni and Mario Malzoni, and also a multicentric prospective study from Eliana Montanari, showing very good numbers for sensitivity and specificity. Now, but it's also important, as we were seeing earlier, when you talk about endometrioma, is the topic of infertility. And for that, we have the EFI, the endometriosis fertility index. The problem with this index is that we can perform this only after we have done the surgery. So the question is there any possibility that we can tell our patients which are the chances to become pregnant without doing the surgery? And for that, we have 2 nice papers from the group of Tomasetti from Leuven, where they basically combine the history taking with the clinical examination, with an advanced ultrasound and HICOSI or HIFOSI, to predict the EFI score and basically tell the patient for the surgery which are the chances for him to become pregnant. Now, how should we perform ultrasound? And here we have the 4 steps recommended by the IDEA consensus from 2016. And doesn't matter if you do the 3rd step first or the 1st step second. What is important is that we don't miss any of these steps. And we'll go through them one by one with a couple of examples. So first, we have to look for adenomyosis. Extremely important. to diagnose this and also to inform the patient, especially when we do a complete endometriosis excision. The patient needs to be informed there's a benefit for her to have a hormonal treatment in case there is some adenomyosis, which can cause patient symptoms of hormonal treatment. And according to the MUSA criteria, we have 3 direct signs which are quite pathognomonical and 6 indirect signs. Here are a couple of examples where you see the asymmetry between the anterior and posterior wall, the fan-shaped shadowing. Again, here, anterior-posterior asymmetry. You can see the typical hyperechoic lesions level of the anterior uterine wall. Here's another example where you can see both cystic lesions and hyperechoic islands. Here again, another example with cystic lesions and hyperechoic islands localized in the myometrium. Now, this is a picture of how adenomyosis looks like during an OSADA procedure, which should be the ultima ratio when it comes to the treatment of diffuse adenomyosis. And then moving to the first step where we have to look at the adnexa, is important to know what we're dealing with. And Angelos, as you were showing earlier, the nice surgeries for the treatment of endometriosis, it's important to know before the surgery if we are dealing really with an endometrioma. And for that, we have the IOTA criteria, which can help us to differentiate between a benign tumor, a borderline tumor, a hemorrhagic cyst, or an abscess after oocyte pickup. Now, also, I would like to share with you this very nice paper, which should be a takeaway message for all the gynecologists here. Endometrioma isolated, it's a myth. That happens in less than 1% of the cases after the surgery. And if you perform ultrasound before the surgery, you will pick up an isolated ovarian lesion in less than 15% of the cases. In the rest of the cases, you'll be picking up deep endometriosis or adhesions or a negative sliding sign or adenomyosis. Again, ultrasound is a real-time examination tool compared to the MRI. So that means we can use both our hands and check the mobility of the organs. And we can look for the soft markers, and we can check the ovarian mobility. And here you can see on the right side, there's an ovary stuck to the intersacral ligament where you see a massive lesion infiltrating the intersacral ligament. On the other side, you can see which is free, adherent to the pelvic side or to the uterus. Why is this important? Because you have an ovary that is not free. That's a sign that you need to perform pelvic sidewall surgery, which means uterolysis, or you have to do a nerve sparing surgery, look for the hypogastric nerve, and so on. So as you can see, ultrasound can help us predict the complexity of the surgery. Now, moving to another real-time tool, the sliding sign, again, extremely easy to perform, but with very important information that it delivers. So again, by placing the ultrasound probe on the anterior or posterior vaginal fornix and mobilizing the uterus, you can tell if you're going to expect a frozen pelvis or not. Very important. Frozen pelvis basically adds 1.5 hour to the surgery you're going to perform. Negative sliding sign, most probably you'll be expecting a less complex. You have to look for endometriosis that might infiltrate the bladder or the intramural part of the ureters. And here you can see the most frequent type of urinary tract endometriosis is the bladder, which is 40 to 50 to 1, compared to the ureter and kidney endometriosis. Looking at the numbers, you see that we have an excellent specificity and sensitivity when we diagnose bladder endometriosis. So how do we do this? We have to place the ultrasound probe in the anterior vaginal fornix, visualize the urethra, identify the trigon, and if you tilt the ultrasound probe, you'll pick up the intramural part of the ureter. And here you can see, you can follow up the ureter all the way up to the crossing with the iliac vessels, using the Doppler and having some patience. Now, Why is this important? Because depending on the imaging diagnosis, we can pick up important information that are going to influence the management. Are we going to have a conservative approach, a surgical approach? Are we going to follow up? Do you need a urologist for the surgery? Is the lesion localized close to the trigone or close to the ureter? Does the patient require DJ stents before the surgery? Am I going to plan this by conventional laparoscopy, or is this something that robotic-assisted laparoscopy? Here are a couple examples where you can pick up this big lesion localized on the bladder base level, on the bladder dome. This is the correlation with the intra-op finding. You can see it's not a lesion that it infiltrates just the bladder, but it also has an adenomyotic component, which is also extremely important to excise and not leave a disease behind. Here you can see the bladder is being open, basically cranial and ventral to the lesion, to basically have a look inside the bladder. Here you can see the adenomyotic component, and here you can see the huge defect that such lesions are leaving behind. In this case, we decided to place DJ stent because on the ultrasound, we had a feeling that the lesion is quite close to the ureters. And this is the moment where the urologist comes in and he can reconstruct the bladder or can have a look, and we as gynecologists perform the surgery further. Now, moving to the ureters. Now, oh, sorry, yes, there was this another video. We also have to look if we're dealing with one lesion or two lesions. In here, for example, you can see very nicely the ureter and the jet phenomenon and two endometriosis lesions. So basically, before the surgery, exactly that the lesions are deep infiltrating. See, relying just on the laparoscopy, you cannot tell if the lesions are superficial or deep infiltrating. So with the help of the good pre-op ultrasound, we know exactly that in this case, we have to perform a partial cystectomy. So it helps us to avoid unpleasant surprises during the surgery. Now, moving to the ureteral endometriosis, very interesting topic, very important. Why? Because in 50% of the cases, these patients are asymptomatic. And this is important because ureteral endometriosis can cause stenosis with hydronephrosis. That means these patients might lose their renal function. Now, looking at the sensitivity, you can see the numbers are not very well, 61, 68%. So in such cases, the more we go lateral, the better the MRI is performing. So what are we going to expect on the ultrasound? We can pick up the ureter, the intramural part, and following the ureter cranially, we can see the crossing with the uterine artery. Here, the Doppler can help you to identify this part. And basically, most of the lesions are localized at the level of the crossing with the uterine artery or cranial of this. So what we'll be looking for is a dilation of the ureter. As you can see here, a hydroureter. So we'll know exactly that we'll be dealing with the lesion that is causing stenosis. So immediately we're talking about complex surgery. We have to involve a urologist. We have to place a DJ stent. We have to perform a renal scintigraphy, check the renal function, and basically decide if the patient requires a nephrectomy or are we going to expect a ureteral reimplantation or maybe just a deeper extended ureterolysis. So here you can see an unpleasant case of a patient who got to us too late, where her left kidney had a renal function of only 4.2%. So in such a case, we're not talking about ureteral reimplantation. We're talking, unfortunately, about nephrectomy. So these are the cases we want to avoid. And with the basic kidney ultrasound, which should be mandatory for all patients having endometriosis typical symptoms, we can exclude a hydronephrosis. So basically, we have three clinical scenarios. I'll go fast through them. So the most, let's say, the case that we wish for is the one with that there's a stenotic lesion on the ureter, and we can prepare the surgery. We can involve the urologist. The patient can give her informed consent, so the patient knows that she should expect anything up to a ureteral reimplantation. So the TVS picks up the lesion, the kidney ultrasound picks up the hydronephrosis, and we are prepared for the surgery, and we can reimplant the ureter. Now, the second scenario, which is, less good for both for the gynecologist for the patient is where we don't pick up anything on the TVS, but we can see on the kidney ultrasound that the patient has a hydronephrosis. So the question is, at which level is the lesion causing the stenosis? Are we talking about a higher lesion, which might be congenital, basically where the ureter comes out the kidney, or are we talking about a lesion localized in the pelvis that we might have missed on the TVS? So in such cases, we have to involve the urologist. We can perform an MRI with a urography, and where the urologist can place directly a stent and see exactly at which level the stenosis is localized. Now, these lesions that we might miss are usually localized higher up. So the higher we go with the ultrasound scanning, the less we can see on ultrasound. So here you can see it's a lesion localized basically on the cranial proximal part of the uterosacral ligament, which is far away from the posterior vaginal fornix, which is the maximum point we can reach with the transvaginal probe. So in such cases, of course, the third scenario, which is as fortunate to say so, is when we go for the surgery and we have such a surprise. So this is a patient that was referred to us with a suspicion of ureteral endometriosis. I scanned the patient, didn't see anything on ultrasound, no hydroureter, no hydronephrosis. So of course, I thought that the colleagues who referred the patient to me misdiagnosed the patient. And here you can see we pick up the lesion on the uterosacral ligament on the right side. And as we evaluate the whole pelvis, we pick up this lesion in the left ovarian fossa. And again, is the same structure involved, the cranial part of the uterosacral ligament. And you can see the ovary is attached to this lesion. And as we proceed with the dissection and we perform the ovariolysis, we suspend the ovary to the abdominal wall, and we continue with the ureterolysis, we can see that this is a lesion that infiltrates quite deep. So in such cases, you have two possibilities. You stop the surgery and you do everything in a second session where the patient gives her informed consent also for the situation where we might have to reimplant the ureter. In this case, we had the feeling that we can proceed with the dissection. So basically, we went on with the deeper uterolysis. Of course, we called the urologist. He had a look. He said everything is fine. He placed a DJ stent, which stayed in for 3 months, and then we regularly checked this patient for the next 12 months to make sure that she's not going to get a chronic stenosis. So this was the anterior compartment, and now I'll move as fast as I can to the posterior compartment. And here you can see the ultrasound probe is placed in the posterior vaginal fornix. You can see the patient has some free fluid. We can visualize the rectum with all its layers. We can see the muscularis propria of the anterior posterior wall, and we can follow up the rectum up to 20 centimeters. So we can visualize on the ultrasound all the structures. So the first structure we should be looking for is the posterior vaginal fornix. And as you can see here, there's a thickening of the vagina. And you can see on the left side, basically dorsal to the vagina, that the bowel is not infiltrated. So in such a case, we know exactly what we're going to expect. Partial colpectomy without bowel surgery. So again, the ultrasound helps us to prepare for the right surgery. Now, moving lateral to the uterosacral ligaments, here you can see that on the ultrasound, we can pick up the uterosacral ligament. Here you can see the lesion on the uterosacral ligament. Keep in mind that these ligaments are quite long, coming all the way up to the sacrum, down to the uterus. So we have a good specificity and sensitivity for the lesions localized on the uterosacral ligament closer to the uterus, and it gets more difficult the higher these lesions go. Now, moving to the bowel, what are we going to see? We're going to pick up all the layers, hyperechoic, hypoechoic. So talking about bowel in terms of black and white. What is white? The serosa. What is black? The muscularis. And what is white? The submucosa and the mucosa. What are we going to look for? A thickening of the black line. So any thickening of the black line is a sign for deep endometriosis. Now, talking about rectal sigmoid endometriosis, which is basically 87% of all bowel endometriosis. The rest is localized outside the pelvis, appendix, cecum, small bowel. Talking about rectal sigmoid endometriosis, the TVS has an excellent sensitivity and seems to be even slightly better than the MRI. Why? Because lesions are closer to the ultrasound probe. So we can pick up very well the lesions localized on the rectum and the rectal sigmoid. How should we measure this? It should be the medial-sagittal plane. What is also important on the TVS is to measure the distance between the lesion, basically the caudal part of the lesion, and the anal verge. Why? Because the distance up to the lesion correlates with the height of the final surgical anastomosis. And we know the lower the anastomosis is going to be, the higher the risk it is for an anastomotic leak. And TVS can help us to predict what type of treatment are we going to perform. Should that be shaving? Should that be a partial thickness resection, full thickness resection, disc excision, or a radical treatment in terms of a segmental resection? Now, going to the surgery, for lesions lower than 3.5 centimeters, we can perform a disc excision. And in this case, you can see on the left upper side, a lesion that was on the rectal anterior wall, and you've seen earlier we've dissected that lesion from the torus uterinus, from the posterior vaginal fornix, and after performing a debulking of the lesion, we've placed a circular stapler inside the lumen of the bowel, and we excised just a patch of the anterior rectal wall. So we can adapt the type of surgery depending on what we're seeing on ultrasound. In such cases of multifocal lesions, where we see on the ultrasound that the patient is having two lesions not far away from each other, we know from the beginning that we have to perform a segmental resection. Of course, anything that's localized outside the pelvis, in most cases, is going to be an intra-op diagnosis, but performing an appendectomy is not a difficult surgery. Cecal endometriosis, it can be more difficult, and maybe this is something we can do in a second surgery if the patient hasn't given her consent for bowel surgery. So I'll skip this slides because I think we're already late and my presentation was longer than 20 minutes. Now, talking about peritoneal disease, we can pick up very well the lesions localized in the Douglas peritoneum. As long as we have a little bit of free fluid, we can pick up these lesions very well because they're very, very close to the ultrasound probe. Now, talking about sacral nerve roots, there's this nice paper from our friend Gabor Szabo, who showed that you can pick up on ultrasound even the sacral roots and any lesions localized close to these nerves. As a conclusion, sophisticated ultrasound should be the primary imaging modality. It has to be performed according to the IDEA consensus and the IDEA consensus addendum, also following the Musa criteria, the IOTA criteria. The surgical intervention to confirm the diagnosis alone is not recommended anymore. And the pre-op imaging performed by adequately trained operators, should that be TVS or MRI, is strongly recommended. Now, TVS plus kidney ultrasound plus a speculum examination are more than enough as a diagnostic workup for most cases. The sonographic assessment of both kidneys is mandatory. We should use the IOTA criteria for the endometrioma. We should all speak the same language using the hashtag NCN classification, use the Musa criteria for the adenomyosis, and keep in mind that MRI is not superior to differentiated scale ultrasonography, especially for the lesions localized in the pelvis. Thank you very much, and thank you ESG for the invitation, and we kindly invite you all to Bologna, Italy next year in April 23rd to 25th, 2026. Thank you.
Thank you very much, Alin, for your brilliant and comprehensive presentation on ultrasound in endometriosis diagnosis. Now it's time to answer to some questions of the attendees. We have more than 200 attendees, and I can see some question to give you. reminding that unfortunately Professor Mabrouk is not with us because he had to operate another endometriosis case. So I begin the discussion with some question. First one is for Professor Angelos Daniilidis. Angelos, are you with us? So in the meantime, please, Alin, answer to this question. What are the key ultrasound features that help differentiate between endometrioma and other type of cysts, which it is a simple diagnosis, but we have to give this information very clear for attendees who ask that.
Yes. So the most typical endometrioma feature is the ground glass appearance, which is basically society endometrioma. The typical feature are the hyperechoic lesions, which usually are hemosiderin, hemoglobin deposits, and they're localized at the dorsal part of the lesion because of the gravitation. In most cases, these are unilocular lesions. Of course, we can have multiple endometriomas, different lesions. So in such cases, we're not going to expect any intracystical papillary structure, which can be a sign for something that might be a borderline tumor or a malignant tumor. So I hope this answers. So these are the ultrasound features. As you know, CA12.5 is not a reliable marker for to differentiate between endometrioma.
Yes. Another question. Open your microphone, Alin.
Yes.
Okay, now it's good. Another question for how is important the operator experience in the accurate diagnosis of deep endometriosis?
How important is the operator skills for the
operator skill, the operator experience?
For the ultrasound diagnosis?
Yes, of deep endometriosis.
I think it's very important. I mean, we have good examples of people working very well with each other. Alessandra Di Giovanni with Mario Malzoni, she's doing the ultrasound. Mario is doing the surgery. This works fantastic. Me personally, I'm a how do you call it? Surgeon sonologist. So basically, I'm performing my own ultrasound examinations, and I do my own surgeries. And honestly, I cannot imagine things otherwise, because knowing exactly what you've seen on ultrasound helps you to know exactly what you're going to expect during the surgery. Relying on somebody else's skills, again, it depends a lot on your partner, the imagist, the radiologist, or the sonographer. If you have a good experience with somebody that has proven to be reliable, so you're not having any surprises during the surgery, or at least not very, very often, I would say this is the way to go to do your own ultrasound examination. But it's not a must. And of course, it helps a lot, because the way you're going to improve your ultrasound skills is, of course, by trial and error. And I can hardly understand a sonographer who is just doing ultrasound without asking for the images, for the videos, or of the surgery, or without being in the surgery to understand what have I seen, what have I missed. That's the only way to improve your skills.
Thank you. I totally agree with you. We had some question for Professor Daniilidis, but he answered. He already answered in the chat room, and we have not any other question by our attendees. So I believe that we can even close this very important webinar on endometriosis, diagnosis and treatment. And thank you, Alin. Thank you.
Thank you all. Thank you very much.
Mabrouk and Angelos, and the European Society of Gynecology, and to the European Endometriosis League. Thanks
Thank you all.
again.
Thank you very much. Have a
Have
nice
a
day.
nice summer. Have a good summer.
Everybody stay safe. Bye-bye.